The title of our quality improvement project is ICU Transition of Care. My name is Bernadette Schmidt, and I'm a current PGY2 internal medicine resident at Wayne State University. The transition of patient care from the intensive care unit to the medical floors has been identified as a crucial time for communication and accuracy in these patients who are already at a high risk for potential harm due to medical errors. The proper transition process for these patients is critical, as the lack of a universal standardized handoff could lead to detrimental consequences. Our community hospital has an open ICU, and an inconsistent transition of care process has been observed. The focus of our project is to formulate a standardized transfer process that improves documentation, policy, and puts emphasis on communication through a multidisciplinary approach with utilization of a handoff template and implementation of a transfer medication reconciliation. To achieve this, we used a root cause analysis to identify areas of improvement in this handoff process. The persons involved, process, policy, and communication were identified as contributing factors in formulating a standardized transition of care process. PDSA cycles were used to test change, and we measured the use of proposed standardized transition of care method and the number of ICU readmissions as part of adverse events. After observing the need for this process to become ubiquitous, we used the PDSA cycle and literature reviewed in order to formulate a transition of care template. This was used in the first PDSA cycle, which resulted in a 53.8% improvement of documented successful handoff with appropriate use of the template and provider-to-provider communication. In PDSA 2, there was a creation of a policy to utilize an existing transfer medication reconciliation within our EMR that was to be used prior to transferring a patient out of the ICU. Internal medicine residents, faculty, ICU attendings, the ICU committee, and ICU pharmacy, in addition to the EMR department, were all educated on the implementation of this new procedure that was initiated. In this second PDSA cycle, 100 charts were analyzed post-intervention. Of these, 61 charts met inclusion criteria, and 27 of the 61 charts had an appropriate use of the transition of care template and use of the transition medication reconciliation, in addition to communication with the primary attending, which was 44%. Of these, there was one rapid response that warranted an ICU readmission. There were 0 code blues after transfer from ICU. And of the 34 charts that did not abide to procedure, there were 3 rapid responses. Overall, there were fewer rapid responses when comparing the patients with the ICU transition of care implemented compared to those without the documented communication, 3.7% versus 8.8%. And the ICU readmission noted should also take into account the inherent fragility of these patients and the population, and the associated morbidity. Despite our small sample size, the trends are promising that align with the impact of our implementation of the ICU transition of care process. In conclusion, the goal of this quality improvement project was to use a multi-system approach to formulate a standardized transfer process to ensure patient safety. In our next PDSA cycle, there will be a pop-up screen when a transfer order out of the ICU is clicked that directs the user to a transfer medication reconciliation page before proceeding. With this new implementation, there will be an increased compliance to abiding to the process, with integration of the EMR with the transfer medication reconciliation. Thank you.